Hi guys. In this video we're going to talk about acute coronary syndrome and myocardial infarction and what the difference is between the two and how we think about these two conditions. This is the first part of a three-part video series on acute coronary syndrome. Why don't we go ahead and get started? So acute coronary syndrome is the acute focal obstruction of a coronary artery. Now, 9 times out of 10, this is due to plaque rupture. An atherosclerotic plaque rupture is causing thrombus formation and thus obstructing the artery. It can be total or it can be partial occlusion. And I should write on here, this is acute coronary syndrome. Now, this is different from an MI. MI is myocardial infarction. And really what myocardial infarction is, it is myocardial cell death or myocardial necrosis. And the way that we know this has taken place is with positive enzymes, positive cardiac biomarkers. Usually we're talking about troponins, but that also can be CK, CKMB. Now these two conditions or these two terms are related, but they're different, and they're actually, the way I like to think about them is that they're kind of overlapping. So if this is the bucket of all things that make up ACS, this is the bucket of all things that make up MI. Now obviously there's some things in the middle that are both ACS and MI. These are probably the things that you've heard about the most. So STEMI lives in this bucket, ST elevation myocardial infarction, and NSTEMI lives in this bucket, non-ST elevation myocardial infarction. These are sometimes referred to as type 1 MIs. This is the typical thing that you would hear about or read about. Rupture of a plaque, thrombus formation, obstruction of blood flow in the artery with ischemia and cell death of the downstream tissue. If the ischemia is, if the obstruction is complete, that's or total, that's a STEMI. This is a total obstruction. And if the obstruction is partial, that's an NSTEMI. Now, to fill in this schematic, there are things that are ACS and not MIs, and the condition that lives over here is unstable angina. So unstable angina is a true ACS event with usually plaque rupture and obstruction of flow through an artery, but the amount of flow that is able to get through is enough to keep the tissue alive. As a side note, some people believe that these two conditions are really the same thing and that there's really no difference other than our troponin assays aren't sensitive enough yet to pick up evidence of cell death and unstable angina, but that's a side note. The most interesting distinction to make here is between all of these things and what lives in this bucket over here, which is an MI but not acute coronary syndrome. The best name for this is a type 2 MI. Some people will call it demand ischemia, and we'll come back to that in a little bit. Now, unlike what's happening in ACS, a type 2 MI is not due to a focal process, but rather it's due to global myocardial oxygen supply-demand mismatch. So what's happening here is that there is nothing acute and focal happening in the coronary artery. Instead, something else is happening that's raising the oxygen demand of the myocardium, or that's decreasing the oxygen supply of the myocardium so that they are no longer matched and you start to get cell death. Now, this can be caused by a number of different things. There's lots of different conditions that can do this. This is when people have elevated troponins but do not have evidence of plaque rupture or artery obstruction. Common things, tachyarrhythmias will increase your demand just because the heart is beating faster. Anemia will decrease your myocardial oxygen supply. Shock will decrease your myocardial oxygen supply because you have less blood pressure. Hypertension can increase your myocardial oxygen demand. Decompensated heart failure will actually do both of these. And, there's other ones, but this is sort of a good place to start. So the reason I make these distinctions and the reason it's important is to recognize that of the 4 conditions listed here, unstable angina, ST elevation MI, and STEMI, and type 2 MI, in all of these conditions, people can have symptoms that are consistent with ischemic chest pain. And we'll talk later about what those symptoms are. In all of these, people can have ECG changes that are consistent with myocardial ischemia. And not unstable angina, but in the other 3, people have positive cardiac biomarkers. So not any one of the, none of these things alone is enough to distinguish between a type 1 MI or a type 2 MI, or acute coronary syndrome and a type 2 MI. The distinction is important to make because the treatment is different. Once you decide somebody has a type 1 MI, you're going to treat them a particular way, and once you decide someone has a type 2 MI, you're going to treat them a particular way. So, just to summarize, acute coronary syndrome is acute focal obstruction of a coronary artery, usually due to plaque rupture, whereas an MI is myocardial cell death, and we detect that with positive cardiac biomarkers. Acute coronary syndrome, there's basically STEMI, NSTEMI, and unstable angina, whereas you can also have an MI that's not acute coronary syndrome, called a type 2 MI, and that is where you have global supply-demand mismatch in myocardial oxygen. In all of these conditions, people can have symptoms, ECG changes that are consistent with ischemia, and except in the case of unstable angina, you can also have biomarkers that are elevated. And so that means that none of these things in isolation is going to be enough to make the distinction. One quick note about the term demand ischemia. People use it all the time. You should know what it means. However, it's not just demand. It's usually about supply and demand. And it's not just ischemia. It's infarction, and you know that because there's elevated biomarkers. So this brings up the question of, how do we diagnose somebody with ACS, and how do we know that it's not a type 2 MI? Well, that's what we're going to talk about in the next video, so stay tuned.